Okay. Um, Good afternoon, everybody. I'm Liu Xiaolei from the First Affiliated Hospital of Kunming Medical University and from the Neurology Department. And the topic today is imaging exam of stroke. Firstly, let's review the two types of stroke. The most frequent one is ischemic stroke, which accounts for about 80%. It occurred when the cerebral arteries are blocked, which contains cerebral infarction. If the arteries are blocked, irreversible, and transient ischemic stroke, the transient ischemic attack, which called TIA, when the arteries are blocked just for a while. The other type is hemorrhagic stroke, which accounts for about 20%. It happened when the artery is ruptured. The two subtypes are cerebral hemorrhage and subarachnoid hemorrhage. All the subtypes have different neuroimaging manifestation. When a person was suspected of stroke, there are two steps to diagnosis. Step 1, the detailed history should be taken and the physical examination, especially the neurological system exam, should be done to find the specific deficits. And most importantly, step 2 is about the neuroimaging. It's very important to confirm the type of stroke, to explore the etiology and pathogenesis, and to investigate the time window for thrombolysis. So when we talk about the neuroimaging, we should know that computed tomography, CT, magnetic resonance imaging, MRI, and digital subtraction angiography, DSA. And there are CT without this, CT without contrast, CT with contrast, and CTA to see the arteries clearly, and CTP, and CTP to evaluate the perfusion of the tissue. And there are MRI with T1 weighted to see the structures, and T2 weighted to observe the lesions, and FLAIR with fluid attenuate inversion recovery, and SWAN, SWI, to detect small hemorrhagic foci and calcifications, and DWI, diffuse weighted image, to determine the acute ischemic stroke, plus ADC to determine the acute ischemic stroke, and PWI to evaluate the perfusion of the tissue, and MRA or CEMRA with contrast to observe the blood vessel. So, and DSA is used extensively to interventional radiology for visualizing blood vessel. Let's see the manifestation of acute ischemic stroke. The left one is a slide of a normal CT imaging. To the upside, we can see in the upside is the front of the head. R refers to the right side, and left ear refers to the left side. The skull is with the highest density. We can see nice, fairly well delineated curves here. We can see the fairly well delineated curves of the brain tissue here. And the age the edges, the surface of the brain look a little different from just below the surface. Is a reflection of the gray matter. The gray matter is on the outside of the brain here, and the white matter on the inner part here. All of them are white matters inside inner part of the brain. And one more thing I might mention is that we can see this normal brain looks symmetrical. But what about a brain that has a stroke? Here, within a first few hours, it would look pretty much like this normal CT. The two has less different in a few hours after stroke. And that's because the changes that happened in the brain during and after a stroke take time to develop. And sometimes you can't see any brain changes on CT until half a day after a stroke occurred, usually about 12 to 18 hours after the onset is when you can start seeing some changes on CT. But in the early stage, you might see a clot that caused the ischemic stroke. So here in the CT, this CT scan showed us a pretty quickly, this CT scan is taken pretty quickly after a stroke at 4 hours after the onset. And what you might notice is this thing here, which is actually the left middle cerebral artery here. It looks hyperdense. This is called the MCA hyperdense sign, middle cerebral artery hyperdense sign, which signifies that there's possibly a clot here to let ischemic stroke happen. So in some cases, maybe one of the things that you can see on the early CT is a hyperdense sign. Now, this scan is taken from at 48 hours after the onset. You can see some swelling here, developing here. The low dense contrast to the right hemisphere, we can see it. This region is supplied by the middle cerebral artery. This is a typical characteristics of manifestation of AIS, acute ischemic stroke, on CT. And from the CT angiography, we can also conduct it for this patient. On the normal CTA on the left side, the Willis circle is very clear, and all the arteries is intact and smooth. By contrast, here, CTA on the right side here showed that the MCA artery is blocked here, and through the CT scan here, we can also find in this patient there is a clot here in the CT, is a MCA hyperdensity. Unlike the CT scan, the MRI is very sensitive to detect AIS, acute ischemic stroke. Generally speaking, on the AIS lesion here, it is characterized by a low or identical signal in T1 weighted here, high signal on T2 here. But the most important trait is a high signal in diffuse weighted image and low signal on ADC at the same lesion, at the same part of the brain. Here we can see which indicates the acute phase of an ischemic stroke. This is a manifestation of acute ischemic stroke on MRI. It's more sensitive. There are the latest guidelines to diagnosis and management of AIS. The neuroimaging is one of the most important techniques. So here is the workflow of neuroimaging of AIS within 24 hours. Let's see the details. The patient presentation within 24 hours of symptoms onset of confirmed acute ischemic stroke or transient ischemic attack if there is a patient here with disabling deficits present. For example, hemiparesis, aphasia, or slurred speech, vision loss, neglect, ataxia, or incoordination within 24 hours from onset. The CTA or MRA should be done to observe the cerebral vessels. So within 4.5 hours from onset, the alteplase, if the alteplase, the drug alteplase is very important for the AIS patients. If it is eligible, we should give alteplase to the patients. And if the patients receive alteplase and with a large vessel occlusion, we could then do endovascular therapy. If the patient with alteplase with not vessel occlusion, we should use a single antiplatelet therapy after the alteplase. If there is not alteplase, there is not any alteplase eligible, we should use the single antiplatelet therapy. This is a patient within 4.5 hours. And when the patient's, the time is in the 4.5 to 9 hours from onset. If there is a large vessel occlusion after the CTA or MRA, if the large vessel occlusion is present, we should do the MRI or CT perfusion to see if the DWI and if the patient has the reversible ischemic tissue. If there is any reversible ischemic tissue, we should do the endovascular therapy. If there is not any, we should do the single antiplatelet therapy. If it's not the large vessel occlusion, if in the MRI, we can see there has a lesion on diffuse weighted image, but there is no lesion on the flare sequence. We can use alteplase. If there is a lesion also we can see in the flare sequence, we just do the single antiplatelet therapy. This is a workflow of workflow of the AIS, how to do within 24 hours. And in this part, we can see the important role of neuroimaging. So here, there is a theory of ischemic penumbra should be explained. More and if there is a block of a vessel, the lesion occurred, and with the time pass, the lesion is become larger and larger. The first dead area is called the dead brain tissue, which is infarct core. We can see it's very with a very low blood flow here. And there also a hypoperfusion area. The normal brain tissue have the 50 to 60 milliliter per milliliter per 100 gram tissue. But the hypoperfusion area has a low blood flow, and the dead brain tissue has the lowest blood flow. And the ischemic penumbra means the hyperperfusion area distract the dead brain tissue area. If there is any volume here, there is a ischemic penumbra. This is irreversible. The brain tissue can be irreversible if there is blood flow. So it's very important for us to determine the therapy. So here is a perfusion study. For example, on this image, we can see the infarct core after calculation is less than 70 milliliter, and the volume of ischemic penumbra is more than 10 milliliter. So we can do the articulate therapy or endovascular therapy here. Now let's move to the manifestation of cerebral hemorrhage. It contrasts to, it's not different, it's different from the ischemic stroke. The CT scan is very sensitive to detect the cerebral hemorrhage. So it is a first choice for the patient if we suspected he is a hemorrhage, a cerebral hemorrhage. So in the acute phase, we can see a lesion is with high density. It has a clear edge, less edema, space occupying effect, and some more worse if it is in the worst condition. In acute phase, we can see the cerebral hemorrhage breaking into the ventricular here. And the worst, we can see the cerebral hemorrhage breaking into the subarachnoid space here. All of they are high density here. And there are some signs suggesting enlarged hematoma. If there is a hemorrhage in front of us, we should detect more carefully to explain it and find the signs which suggesting enlarged hematoma. So CTA spot sign is this. We can see in the CTA some contrasted more density part here. The spot sign here, here, and here. And in a normal CT scan, we can see the blend sign. Here is with a high density, but here is with a lower density, contrast to the higher part. And black hole sign, that means in the hematoma, there is a black hole, which suggests the hematoma will be enlarged in several hours or several days. And here is an island sign, which this is island, the high density island in the outside of the large hematoma. If we use MRI to detect the hemorrhage, it's not so easy for us to detect because the manifestation of cerebral hemorrhage in MRI is different in the different period. For example, in the superacute period, we can see the identical T1 weighted, but the high signal in T2 weighted. And in the acute period, we can see the low T1 weighted here and low T2 weighted here. And in the early subacute stage, we can see the core, it have the identical T1 weighted and low signal in T2 weighted. But the peripheral areas, we can see the low T1 weighted, but high T2 signals. And in the late subacute stage, the core is with a low T1 signal, but high T2 signal. And the peripheral areas is a no T1 signal and low T2 signal here. The low T2 signal refers to the signal is more grayer than the normal tissue. And in a chronic phase, the core is high. Where here, the core is high T1 weighted, and here, high T2 weighted. But the peripheral areas, the high T1 weighted here, and low T2 weighted here. So it's very complex on the MRI. And the last subtype of hemorrhage is subarachnoid hemorrhage. The first choice is also the CT scan. We can detect the high density bleeding sign here in all the cisterns or pools. So this is here. This is a anterior longitudinal facial pool, and here is a suprasellar system, and here is lateral facial system, and here is cerebellar pontine system, and here is ambient system, and this is a posterior longitudinal facial pool here in the green one. We can see high density bleeding signs here, all of these. And we can detect more than 90, through CT, it can detect more than 90% of SAH. SAH means subarachnoid hemorrhage. And the arterial aneurysm accounts for 75% of the etiology of SAH. So we can take CTA or DSA to detect it. Here we can see there is an aneurysm, a very large aneurysm here through the DSA. And through the DSA, we can see the aneurysm here. If we find the aneurysm, if the SAH is due to arterial aneurysm, suitable surgical therapy should be done to remove it. So the CTA and DSA is very important in these patients. So one more question for us, for all of you. There is a 70-year-old man suffered from a sudden onset of numbness and weakness on his right side during breakfast. When he was sent to hospital, what imaging should he be taken firstly? CT or MRI or CTA or PWI? Can anybody answer? Here, we should take CT at first because the sudden onset of neurological deficits in this old man suggests us stroke. But we cannot determine the subtype in this time, right? We cannot distinguish ischemic stroke or hemorrhagic stroke at first. So CT is sensitive to hemorrhage with few seconds or minutes to conduct and spend less. So it is a first choice. Okay. Lastly, the take-home message. The diagnosis of stroke includes the symptoms and signs of neurological deficits with acute onset, plus the important imaging findings. And the first choice is cranial CT to exclude cerebral hemorrhage. The MRI and diffuse weighted image plus ADC is very suitable for AIS patients. In the acute phase, the cerebral infarction, perfusion imaging is suggested to determine whether there is a tissue thrombolytic window. CT scan is the most suitable imaging for cerebral hemorrhage and subarachnoid hemorrhage. That's all for today. Thanks very much.